Here we present a technique for AC joint reconstruction using an artificial ligament and Palmaris longus graft construct. With the patient in the beach chair position, prior to prepping and draping, the stability of the AC joint is assessed. Following prepping and draping with an occlusive drape over the shoulder and forearm, the Palmaris longus is identified at the wrist crease and harvested through 3 small incisions with injection of local anesthetic and adrenaline to minimize bleeding. Care is taken to harvest the tendon up to the muscular tendinous junction in order to maximize tendon graft length. The Palmaris longus graft is prepared using a looped whip stitch at both ends. The landmarks are drawn prior to application of the dressing, and the AC joint is approached via a saber or bra strap incision. The lateral end of the clavicle is defined, and the deltotrapezoid fascia is incised using electrocautery. Then a small window in line with deltoid fibers or in the upper part of the deltopectoral groove is developed. The AC joint is then approached from superiorly. And a combination of blunt, sharp, and electrocautery dissection is used. The aperture and approach to the coracoid is developed, and the scarred ligaments are released from the base of the coracoid. A channel is created for passage of the graft and ligament. The borders of the coracoid are defined and releases performed as required. The sided passer is then passed underneath the coracoid base from medial to lateral, and the passing wire is shuttled antegrade for retrograde passage of the ligament and tendon graft. The leading suture through the loop of the ligament and leading sutures from the tendon graft are passed together, ensuring that there is free running of both components. The free ends of the ligament are passed through the loop in a luggage tag fashion, and this is secured around the coracoid, ensuring that the graft remains free running. The ligament is then cycled to remove excess slack and to reduce any residual soft tissue between the graft and the bone. The guide wire is inserted through the clavicle under image intensifier control, followed by a cannulated drill to exit inferiorly at the level of the conoid tubercle. The coracoid passer is then used to shuttle the wire loop antegrade, and the free ends of the ligament are retrieved retrograde through the clavicle tunnel. The free ends of the ligament are passed through a small metal button, and it is ensured that the limbs of the graft remain free running. Both limbs of the tendon graft are then retrieved anterior to the clavicle . The ligament is then secured over the button with a half hitch while an assistant is maintaining reduction of the AC joint. This is locked with a simple suture. The coracoid passer is again used to shuttle one limb of the ligament under the coracoid. The medial limb of the tendon graft is then retrieved anterior to the lateral limb and passed in retrograde fashion under the clavicle, lateral to the artificial ligament in the line of the trapezoid ligament. The free ends of the ligament are then secured under tension with multiple half hitches and locked with a suture. The ligament is trimmed and the knot stack is buried under trapezius. The sutures from the graft whip stitch are then secured superiorly over the clavicle. Skin closure in standard fashion, and image intensifier images confirm adequate reduction and stability of the AC joint.